Leong. I'm an endocrine and general surgeon. And first of all, I'd like to thank Cheryl and also Hollywood Private Hospitals for making this possible. I'd like to warmly welcome all of you here, as well as those that are online on Zoom, to the meeting today. And today's meeting, we'll be talking about, or focusing on thyroid nodules. And then my colleague Imran Raja, who's an endocrinologist, will be talking about interpreting tricky thyroid function tests. So, the prevalence of thyroid nodules is certainly increasing, and it's estimated that perhaps up to 65% of the population has a thyroid nodule or thyroid nodules if you were to screen them all. And probably that's in part related to the increased use of diagnostic imaging and also the improvement in terms of the quality themselves of diagnostic imaging, where we're picking up probably smaller and smaller nodules over time. As expected, the majority are incidental, and probably about 7% or so are actually clinically evident. So I think when I think about assessing a thyroid nodule, the three things that I sort of think about are symptoms. Does the patient have any symptoms? Followed by, is there any increased function in particular? And also, what's the risk of malignancy, and does this nodule need to be removed? When we look at symptoms, so I guess one of the things that we think about is compression. And compression can range from one end of the spectrum, for example, in this patient. So this is a lady who actually is a highly functioning lady. Actually, she sold medical insurance, but she was quite paranoid actually about seeking any advice about her healthcare. So she presented really late, actually, in respiratory distress with a goiter that was massive. And you can see that with this lady, there was significant compression of the trachea, almost down to 2 millimeters. And so she had all the symptoms of inability to lie flat. She was dyspneic on exertion, and she couldn't lift her hands above her head because all the sort of venous congestion. And in fact, she had an emergency thyroidectomy done, and it had to be done under an ECMO, so under bypass surgery. So they couldn't intubate this lady. But she had an uneventful recovery otherwise. And so sometimes they present like this, but sometimes they present like this patient, for example. So this is a young girl who self-noticed this lump. If you look at the clinical photograph on the left side here, you can sort of see that there's a subtle swelling on this side. And so for her main symptoms were that she noticed this nodule every time she was swallowing. She should feel it when she was touching the neck. And I guess once you notice something, you're more likely to keep feeling the nodule. But with nodules that sit between, so that's the trachea here. And so when the nodule sits in the isthmus or in the interior part of the thyroid gland, between the trachea and the strap muscles and also the skin and subcutaneous fat here, it's quite a fixed space. So in these type of nodules, even though they may not be as large as you think it should be, but other ones, the patients are more likely to be symptomatic. So they may have some impressive symptoms there. I say that these nodules typically are anywhere from about 2 centimeters onwards. Whereas, the ones that you see sort of in the mid-pole of the thyroid gland are less likely to cause any significant symptoms. And those are the ones that are often incidental and of little concern to the patient at all. And then I think dysphagia and globus are very difficult symptoms to treat often, and patients often get investigated for a thyroid pathology with a complaint of dysphagia. I have to say the majority of dysphagia and globus is not fixed by a thyroid operation. However, I think things to be mindful of is that if you look at the ultrasound here, this patient in particular had a very sort of posterior nodule in that tubercle canal or the back part of that thyroid gland. And if these nodules get usually to about that sort of 3 centimeter kind of mark as well, sometimes that can compress on the esophagus because the esophagus sits adjacent to that part of the thyroid gland. And so in this patient who had a barrier swallow, you can see that there was some degree of compression there. She actually had a significant improvement after having that removed. But as I said before, the majority is not. And I think the key thing is that you need to prove it with some sort of swallow test to see if there's any true compression before consenting with an operation. So I think that the things that we would be worried about is if the patient complains of a voice change, hoarseness of voice, that often will indicate malignant infiltration of the recurrent nerve that sits adjacent to the thyroid gland. Rapid enlargement, typically over weeks, is often associated with either an anaplastic thyroid cancer or lymphoma of the thyroid gland and should be referred urgently. We often admit these patients if they report significant enlargement over a short period of time to the hospital and any development of stridor or significant difficulty breathing. So if the patient doesn't have any symptoms whatsoever, then one of the other things to think about is function. I put hypothyroidism there, but the main thing I guess you want to know is that whether or not these nodules could be hyperfunctioning, and that could be done easily through a thyroid function test. And if the TSH was suppressed, then you might be suspicious that it's possible that they may either have a toxic adenoma, they could also have Graves' disease or a toxic multinodular goiter. So if that were to be the case, then you follow up with a thyroid uptake scan. And I just put hypothyroidism there because if patients have autoimmune thyroiditis or Hashimoto's disease, it's not uncommon, depending on where they go for an ultrasound, for there to be nodules seen, but often these nodules aren't easy to see and they're rather sort of called pseudo nodules. So you may find that if the patient goes to a different high volume provider, there may be no nodules seen instead, as opposed to other ones. So just something to bear in mind. But if you do a thyroid uptake scan, in summary, you could get one of the following. And I guess in a patient who has thyroid nodules, you'll be looking to see if there's uptake in multiple nodules. You're setting up a multinodular goiter, and it will indicate that they have a toxic multinodular goiter, or uptake in the dominant nodule itself, or that single nodule, which would indicate that they probably have a toxic adenoma. I think something we often taught in medical school as well is that toxic nodules are almost never malignant. They don't need any biopsy. I don't think that's true. I think maybe 1 to 2% of these nodules can be cancerous, and we've seen that before as well. So I think rather than just assuming that a hot nodule is never cancerous, taking everything else into account, and I'll talk about those other features later on, are also pretty important as well. So in terms of what treatment options if the patient has a toxic goiter, Graves, or an adenoma, I just sort of summarize what options there are. So there's definitely medical treatment. The downside, I think, of medical treatment is that it doesn't give you a definitive histological diagnosis. So if there's any suspicious nodules or the patient has compressive-like symptoms, then they won't be relieved of that. Also, it's often lifelong, and not everybody is tolerant of these medications, but in someone who's comorbid and isn't suitable for any other form of definitive treatment, then it's not unreasonable. Then there's radioactive iodine therapy. So it can be quite effective in toxic goiters and adenomas. However, maybe about 30 to 40% of patients may require second treatment. It also isn't suitable if they're trying for a child, so you can't really try for pregnancy, usually after about 12 months. It's also difficult for treatment if you have young children because you have to isolate yourself from them during that period of time. It also doesn't give a histological diagnosis. And furthermore, I think that there is also a negative perception about radioactive iodine therapy. I find that often when you mention this to patients, most patients are reluctant to ingest radioactive sort of capsules, even though they can be quite effective. And it's probably first-line therapy in America, for example, because I guess in terms of surgery, whilst there is surgical risk, and the cost involved. In general, I would say that surgical risk for an operation, the risk of anything going wrong is typically less than 1% for most patients. So if the patient doesn't have any symptoms and is non-functional, then the last thing really is to think about, is there a risk of malignancy in this nodule? And I sort of think about it based on these sort of 3 headings. And so the first are patient factors, and what are the radiological sort of features of the nodule or nodules themselves. And then finally, if a fine needle aspirate is performed, what's the cytology result? So we talked about the red flags before, but things that are important is whether or not they have a family history of thyroid malignancy and also prior head and neck irradiation exposure. I'll say that head and neck irradiation exposure is more common in sort of that pediatric group who have had radiotherapy for a brain tumor, for example, and we see that through the Children's Hospital. Other than that, it's pretty uncommon, unless your patient lives in Ukraine during Chernobyl, for example, which is pretty unusual. But I think it's still important to ask because in a patient who's had head and neck radiation exposure, the entire gland is at risk of developing malignancy over a period of time. And most nodules are about probably double the risk of malignancy compared to someone who's never been exposed before. So in terms of radiological findings, I guess they can be detected on ultrasound CT or PET CT scans, but I think the key one and the most sensitive test for thyroid nodule is an ultrasound. I think doing a CT scan and PET CT, often that's an incidental type finding. We'll talk about that in a moment as well. But on sonography, there are sort of two main ways nodules are stratified into the risk of malignancy. And one guideline was developed by the American Thyroid Association. And I actually find this stratification a lot easier to use because all you need to do is sort of remember keywords that show you that the nodule is at risk of malignancy. And so the keywords really is that if the nodule is very solid, typically it is hypoechoic, so very black and dark. So you can see these nodules here, which are of high risk, are very black and dark. So hypoechoic is bad. If they have microcalcification, so if you look at this one over here, you can see these little microcalcifications with those white dots, and that usually indicates that it could be papillary thyroid cancer. So if you see that, that's usually a concern. If it's irregular sort of its margins, then you think that it probably is malignant and infiltrating around out of the thyroid capsule. And then finally, the presence of abnormal periodicity. So the radiological findings sort of lead on to the next thing, which is actually just the size of the nodule. So if the nodule is suspicious, then depending on its size, a biopsy is then recommended. And the reason why we don't biopsy for thyroid nodules is that because historically we used to probably biopsy almost everything that was over a centimeter. But what we found is that we were really busy and it's great for us, but it's probably over treatment and over diagnosis in terms of benign thyroid nodules. So that's why there's been a step back and de-escalation in terms of biopsying anything. And usually it's a size criteria and also the characteristics of ultrasound. So the next common sort of, I guess, scoring system is the thyroid scoring system. And you see that quite frequently, depending on which provider you send your patient to for an ultrasound. And so the thyroid system sort of is predominantly, I think, probably developed from Europe, to be honest. And what it is very similar to the Americans in the sense that if you look at the scoring system there, what it is that, you're looking for solid nodules, hypoechoic nodules, as you said before, sometimes taller than wide. Is it sort of irregular in its margin? And those microcalcifications. And then you get a total score. And ultimately, anything more than a score of 3 usually means that you shouldn't biopsy it if it gets to over 2.5 centimeters. Anything that's 4 and 5 usually is pretty suspicious for malignancy, and depending on which category and size they get biopsied. I think whilst this is a useful scoring system to reduce inter-observer sort of variability, it's definitely much more difficult in clinical practice. Like I ultrasound patients in my rooms all the time. I certainly don't tally up these points and try and figure out which one they fall into. I think it's easier to sort of describe the nodule and then you know which one's bad. But I think if you take away something here, typically something that's thyroid 4 or 5 is usually concerning. And so if they meet the size criteria, then they end up often having a fine needle aspirate for a cytology result. And I think it's important that in Western Australia, each cytology lab will give you different results. We tend to send most of our specimens in the tertiary setting to PathWest anyway, and so they validated their results. So these results are based on PathWest sort of validated results. And so you could get a non-diagnostic biopsy. In those nodules, if we were to just do an operation, it's up to a 10% risk of malignancy for those. Benign nodules don't have a risk of 0, so you can still have a risk of about 1 to 2% in terms of benign nodules. And that probably also reflects a sampling error. So if you've got a large nodule and you're not sampling the entire nodule, it can be difficult to tell whether there's malignancy or not. Indeterminate one's 10%. Another one I get questioned a lot quite frequently is, you get a biopsy that says it's a follicular neoplasm or berthel cell neoplasm, an oncocytic neoplasm. That doesn't mean they have malignancy. It just means that if you took all of them out, about 20% to 25% are malignant. And then if you get anything else other than that, usually it's very likely to be malignant. So So sort of decide what to do if your patient comes back with those results. I think if you have a non-diagnostic or indeterminate result, it's not unreasonable to have a repeat biopsy in about sort of 3 months' time. We don't recommend doing it any earlier because when they do a biopsy, there's often bleeding. So if you repeat it fairly quickly and you get a bloody sample, then often it doesn't return a different result. About 50% of patients who have a repeat biopsy will probably get something that's diagnostic. If you have a benign biopsy, what most recommendations are to do a repeat ultrasound in about 12 to 18 months' time to assess for interval growth, which can be concerning, but also to consider repeating the biopsy to ensure that it's definitely a benign nodule. And then if you return anything else, I think it's reasonable to refer the patient onto a discussion about whether or not they want definitive treatment. So to touch on the last two, I think that CT scans aren't really helpful. A thyroid nodule is detected. Often an ultrasound is required to really assess that nodule further. CT scans can be helpful to assess the degree of retrosternal extension. It's also pretty helpful to assess sometimes for lymphadenopathy if you think they've got significant metastatic disease. CT scans are good to stage the patient for local, regional sort of invasion of their digestive sort of tract structures, which are pretty uncommon. And we almost never PET CT patients as the first line. I think a PET CT is usually an incidental type finding. But all PET-avid nodules have up to a 30 to 40% risk of malignancy. So if your patient returns a PET-avid thyroid nodule, it's important that they get followed up at some stage with an ultrasound and biopsy, depending on the prognosis of their primary tumor naturally. And that sums up my talk. Any questions? Yes.
You get a fine needle that just confirms colloid nodule.
Yeah.
Can you just leave that forever alone, or should you follow up?
Yeah, so I think that we'll do some cases in a moment as well. It'll be interesting. But I think I would say that even if you return a benign sort of colloidal type nodule, depending on the appearance of the nodule, the size of the nodule, I think it should still be followed up at least with a routine ultrasound, and depending on the appearance, possibly a biopsy. Yeah. I wouldn't be falsely assured by a benign biopsy. And yeah, and we'll do a couple of cases in a moment as well. And that will sort of highlight, the problems I think sometimes if we would just rely on a single report. Yes. Yes. This one, yeah.
A question in chat this one.
Okay, hang on. So, is that the?
It's all right, I'm doing.
So is there a question on Zoom? Could you, I think we can hear you. So if you unmute yourself, might be able to hear you.
I'm loving this cut. And question.
Can you hear me?
Oh, yeah. There's somebody there.
I put a question in. Can you hear me?
Okay, so the question, can't quite see is, there's a question on Zoom to say, what are the rates of complications that we quote for a thyroidectomy and hemithyroidectomy? So I tell my patients that we look at my numbers, so every surgeon is different, but the risk of bleeding is about 1%. The risk of permanent recurrent injury is less than 0.5%, so usually about 1 in 300 cases or so. on the risk of a temporary nerve palsy. So for some reason, in some patients, the nerve just doesn't work after the operation, despite being visually identified, and that's probably related to multiple things like anatomical type factors. It's about 4 to 5%. It recovers usually within up to 3 months and sometimes within a year, but can be 4 to 5% in some of these patients. In a total thyroidectomy, the risk of permanent hypoparathyroidism is less than 1%. About 5% of patients will need short-term calcium and vitamin D in the interim period while their parathyroid glands recover after an operation. After a hemithyroidectomy, I say 10% of patients need thyroxine. It depends on what their preoperative TSH is like and what their gland looks like. So if someone's got Hashimoto's or they've got heterogeneous appearing gland, you know that they're probably going to end up on thyroxine anyway. If you do a hemithyroidectomy and the TSH is already borderline. Infection is less than 1%, and then there's always scarring, which varies from individual to individual. And then finally, seroma formation, which probably occurs in about 10% of patients. But the overall risk of anything permanent or anything significant is usually less than 1%. Is there any other questions? Let's do some cases now.
Not coming up on the screen yet.
Yeah, I'm just going to share it. You want to do this. Okay, fantastic. So, okay, so we're going to cover cases. We'll try and see if this works. You take out your phone and you put this into your phone to scan that with your camera. There will be a few questions where you get to sort of call and put in what you think the best sort of management is. It'll be interesting to see whether there's any sort of different responses you may, I guess, facilitate further discussion. Does this work? Okay, so the first case, and this is a 39, these are all real cases, by the way. So it's a 39-year-old gentleman who basically self-noticed this lump in the mid-height of his neck when he was shaving. He's got otherwise no symptoms whatsoever. It bothers him slightly, but he's not terribly symptomatic. He's got no significant past medical history, doesn't take any medications at all, no prior neck surgery. And he said his mother, probably at the age of 50 or so, had some form of thyroid cancer. Had a thyroid taken out, but it's done quite well, so she's still alive and well. So he proceeded on to have thyroid function tests, and it was euthyroid. And the ultrasound shows the following, which was a Pyrex 5 nodule that measured 3 centimeters. So an FNA was recommended. So he proceeded to have an FNA done through a reputable provider and also lab. These were the cytology results. So if we look at that first question, what do questions do? I think there's 18 of us on there. Someone must be sitting on the fence. Okay, so clearly no one must have discharged this patient, which is very sensible. And I think majority recommend observation, probably the ultrasound, which is not a problem. But I'll tell you what happened to this patient. So this patient got referred to me. When I saw him in the room, that nodule we'll go back to that nodule. He was quite anxious given his family history of thyroid cancer. The family history of his mother having thyroid cancer, so he was anxious about this nodule. But when we look at this nodule, remember we talked about those features before, that it's quite hypoalcoholic, so you see it's kind of black. It's got these sort of microcalcifications. So looking at a nodule, it just didn't look like a benign cystic or spongiform type nodule. So I think if you have a cystic nodule that returns a benign biopsy, they're almost never going to be anything of concern. If you get sort of a solid nodule with any sort of calcifications and things in it, then you have to really question, whether it truly is a benign nodule or not. So if it's got any of those ugly features that we talked about before, then I think it's something to sort of think about. But arguably, if you had an ultrasound in 12 months and a biopsy, it would be fine. It wouldn't have probably changed his prognosis significantly. But he had a hemithyroidectomy and he had a 3.3 centimeter biliary thyroid cancer. It was actually multifocal with positive central lymph nodes and lymphatic invasion. So he went on to have a completion thyroidectomy, which was uncomplicated, and it's been referred on for adjuvant REI therapy. So I think the takeaway message from that case really is that if you have an ugly benign sort of nodule, you see those sort of keywords in the ultrasound, for example, then it's probably pretty important that you definitely bring them back for a repeat ultrasound at a minimum or consider referral to the patient's anxious. So do the next case. Does case 2 come up as a question now, or is it not? No, it doesn't. Okay.
David,
Yes.
so like the first case, shouldn't we get more guidance of the radiologist who sees the nodule? Because nowadays we only get paper report words, we get words from them, right? If they say benign.
Yeah, I think that's the problem in that. I mean, these cases are here to highlight, I guess, not sort of more sort of common things. By and large, the majority are going to be benign and fine. But I think, it is difficult, I guess, when we're all busy, we kind of scan the report, you just read the summary and you go, fantastic, benign nodule, nothing to worry about. But I think it's important to sort of, I guess, if you just read the radiology, because often what happens is you get a radiology report and then they're quite good and they send you the cytology result at the same time. So you get sort of both at the same time. So I think if you see like, TARIS 5 nodule or, hypoechoic nodule with microcalcifications and you get a benign result, you probably just need to be a little bit more cautious and sort of, I guess, reassuring and dismissing or discharging the patient, sorry, is what I would have. Most thyroid cancers are pretty slow growing. So you don't really lose the patient as long as you follow them up within a fairly reasonable period of time. And that's why I said repeating the biopsy is important, even in benign nodules, unless the nodule is completely cystic and spongiform. Or you can send it to me, I'll see the patient for you. But I think that the thing is it's difficult, and the main thing is even benign nodules need follow-up. Yeah. And we'll do the next case now. I think this is another one that shows that. So 2 weeks after that gentleman, this is another lady I saw. So this is a 26-year-old lady girl who actually noticed the left nodule on the side of the neck herself. She was fairly mildly symptomatic. It was her main issue being cosmesis. She noticed sort of this swelling. She had a history of a craniotomy when she was much younger for a benign brain tumor, but she didn't have any head and neck radiation afterwards. And apart from being sort of obese, didn't really have any significant past medical history. So she proceeded on once again to have thyroid function test, and in this setting, she was euthyroid. Had an ultrasound of the thyroid gland, showed this sort of large 4.6 centimeter right sort of thyroid nodule. So she went to have an FNA given the size, and so he basically returned a benign colloidal nodule in this setting. Once again, from a reputable sort of imaging provider as well as a pathology provider. So if we go now, if you go back to that now, I guess what would you do next in this setting? What do you think this patient should have next? Okay. There's still a few people sitting on the fence, but I think the majority of the this patient probably benefits from surgery. Maybe because we've been burned by the first case, but probably more so because they have symptoms, right? I guess if she's got mild symptoms and it's a fairly large nodule. If she had no symptoms and the nodule was 4 centimeters, then perhaps what we choose to do may be a little bit different. So anyway, she was referred, given the symptoms and went for surgery. So this is what a gland looked like at the time of surgery. She had a right hemiathyroidectomy, which was uncomplicated, but unfortunately for her, she had a 5 centimeter angioinvasive follicular thyroid cancer, despite having a benign bowel, which kind of expected. And then, so she then required a completion thyroidectomy because with angioinvasive cancers, there's always a higher risk of distant metastases, just being referred on by RAI therapy. And so I think the take-home message for these ones is that if you have a large benign nodule, you have to be a little bit cautious in the sense that depending on where the needle has gone into that nodule, you might in turn colloid, because there could be colloid in that nodule itself. And I think anything more than 3 centimeters, you should have a high index of suspicion and watch that nodule really closely or consider referral if the patient has symptoms. And I think if we repeated the biopsy in this setting, you could get the same result again sometimes because once again, the nodule is quite large. The other thing sometimes it might have returned is it may have returned a follicular neoplasm, and then the patient would probably be referred for surgery anyway. So I think that's the main thing to take away from that one. Any questions about that case? So then the last case is this is an expected photograph because I didn't get one before, so I should borrow one. But it kind of look exactly like this. So he's a 61-year-old gentleman who was referred because he was found to have a retrosternal goiter on ultrasound. And he basically had been having this recurrent asthma attacks for many, many years and was seen a respiratory physician. And so apart from some hypertension, sleep apnea, and the asthma, he didn't have really any other significant comorbidities. And so this ultrasound, it sort of showed sort of large bilateral enlargement up to about 8 centimeters extending retrosternally. He actually didn't really complain of any significant, compressive-like symptoms. And he was more concerned about his asthma attacks. Actually, that was the main thing that he was quite concerned about. There weren't any suspicious nodules in that thyroid itself, so I don't report him having any significant biopsies because they all look quite broad and solid. Otherwise, he didn't have any biopsies. So the question is, what do you think you would benefit from next? You know the example. Yes, well, I think we've got something with that bit. Okay, so I think most people will do a CT neck chest, and I think that's very reasonable. So in a patient who has a retrosternal gland and someone who especially is quite difficult to examine, which would be him in particular, it can be very helpful. And this is actually CT of his neck and chest. So, if you look at that picture on the left here, that's the part of the trachea. That's how it should look like. And that's not really impressed. But as we get down to the direct inlet, you see that the bilateral enlargement is really squished that trachea by more than sort of 50%, really. And in the thoracic inlet, so this is where the problem arises because you have a fixed sort of vertebral body back there. You have your sternum or manubrium and the clavicles there. And then you've got carotid sheath and muscle. So it's quite a fixed space. So as that gland becomes bigger and bigger, and the one thing it tends to squish first is the trachea. And so his asthma attacks was actually related to his significant tracheal compression. So he underwent a total thyroidectomy for this, and actually came off most of his parts to the surprise of his respiratory physician. And his trachea was quite chronically indented because he had this for many, many years. But it usually goes back to normal. And so I think the key for this is that if you have a patient with a retrosternal goiter or someone that's very difficult to assess clinically and you don't think you can get below that thyroid gland, it's definitely useful getting a CT of their neck and chest to assess the degree of tracheal compression. And a lot of patients may have tracheal compression and complain of things like, exertion of dyspnea, or when they get an upper respiratory tract infection, they say, I can't breathe. And the reason why they can't breathe is because the secretions go down and the lumen's only so big. So actually struggling because of the luminal compression. And so that was all the cases I had this week. Any other questions? Yes.
From presentations, it seems that biopsies are not that great.
No. So I've presented unusual cases, but I think the biopsies are reasonably good. But what I think is more important is that rather than relying on one modality, I think it's important to take all things into consideration. So things like your patient's factors. If they've got of course voice, but the nodule's benign, you probably start to think maybe this doesn't sound right, or if they've got a family history and that sort of thing, then you should be concerned. And if the radiological findings just look suspicious, then your index of suspicion should be different to a different nodule that's completely cystic and probably a benign thyroid nodule. Is the main thing that I'm trying to sort of get across here, I guess. I mean, you can't refer everybody for assessment because that will be a lot of patients. But I think just looking at those key things will help you make that decision for that patient, and it could make a difference for them.
I think these are, just remember, these are NAs, these are not core biopsies. And as the size of the nodule goes up, your reliability on the biopsy becomes really less, because you would be lucky if you get the right sample. Especially if they're cystic nodules, they're full of fluid. You don't know, it's like a mess. The smaller and more solid the nodule, then you can, I think, rely more on the biopsy, because you can get a more solid tissue that can be looked under the microscope. So that's what I've been following. The bigger and cystic nodule, I don't really, trust the biopsy that much. If it's a bigger and cystic nodule, if the size is about 3.54 centimeter, I just refer them to my colleagues. And often it is like more than, I think, 52. Of course, more than 60% of the time they are cancers.
Yeah, because we don't get to see the film, so we get to see the report.
Yes,
So
it
the
is.
report is also very operator dependent.
The report is usually
Yeah.
benign, and then we get biopsies, they see the benign or
I mean, it is difficult. I mean, I look at the images. I often look at where the biopsy has gone. If it looks like it's gone into something cystic, as I'm saying, then you'd be more worried that they haven't got the solid component, for example, of a nodule. And I also scan the nodule myself. I just find it a lot easier than trying to scroll through the 100 images. If you talk to the patient, within like 10 seconds, you can tell that nodule's concerning or not by doing an ultrasound. So I think all those things help. But yes, you can't refer everybody, and I get your point. It's not easy because we rely heavily on the report. So I say, I think if you choose a high volume provider, and I don't want to mention too many names, but if you choose a good provider, then generally they will give you a good report, and then they send the cytology to a decent pathology center, and then you get a good cytology report. So what I've found in my experience as well is that no cytology lab is the same, and no cytologist is the same. And so it's quite important that you get someone who's looking at hundreds of these, not 10 of these or something in one. So generally, if your report comes from PathWest, it's pretty good. Most of that's quite reliable. I think Western there's not a problem as well, but certainly the bulk of the work goes to PathWest in terms of thyroid pathology. So they have a lot of experienced cytologists and pathologists there, and I think you can trust those sort of reports a lot more.
Who would you use for imaging provider and the biopsies?
For the imaging, yeah, I think I say that my experience with PRC and SAG has been reasonably good. It depends on where as well. I think capital radiology isn't too bad. If you're in the sort of Netherlands area, one of the best providers is probably Morgan Cartoon. Morgan Cartoon is an excellent radiology center. One, because he runs the place, so you can contact him directly. He's very passionate about what he does. I think he finds things that most people can't find actually in the but so if you're in that area, they're often ones that you can send very difficult biopsies to, and it usually gets most of them done. Yeah, but I would avoid small centers if you want that. Yeah.
And
So-
vision is good as well.
Yeah, I haven't used much, so you know,
Yeah,
you just
yeah,
depends on where you go. But I think if you stick to the same one and you see that they're giving you know, good reports, and the pathology comes back, general pathway's pretty good.
So there is no red flags and you repeat it every 12 months and it's benign. Can you stop there or do you kind of go through the years?
Yeah, so that's a good question. I think nobody really knows how long you should follow up these for. Most of the time, I must say, we end up discharging them back to you after about a year or so, and we kind of say, you know, to follow up. And by follow up, I think we kind of assume they follow up almost definitely, but probably after about 4 or 5 years, you probably give up, or the patient gives up altogether, and that's probably the end of that, you know. But if it grows in that period of time, then I tell my patients, you know, small things that grow slowly still become pretty big after 2 decades. You know, if something's growing by half a centimeter a year, after 2 decades, still pretty big, right? It's like adrenal tumors that we see quite commonly. And you can fall into the trap sometimes of that word that radiologists will say, no significant interval change. But if you actually look at the measurements, they might have increased by half a centimeter or a centimeter, but there's no. So what happened is over a long period of time, this thing is getting slowly bigger. And then it may be that they get discharged and then 10 years later, they come up with a massive sort of thing. So it doesn't happen commonly, but that does happen from time to time as well. Yeah. So I think the bottom line is it's hard because we rely on reports. But I think, you know, if you spend a little extra time spotting those key things, then, you know, you might not run into sort of one of these situations, I suppose. But these are not common. And most of the time, a benign nodule is a benign nodule. And most of the time, they may not increase. And the majority of nodules that we do are not cancerous. The majority are not all cancerous.
If the size, I think if I repeat it after a year, if the size grows more than 20% what it grows, I will repeat it then.
Any other questions? Okay, thank you very much.